Good morning, everyone. Welcome to this week's vertical integration. We are doing fussy eating, specifically in children. As you can see by our beautiful panel so far, we have Gina Steer, who is an accredited practicing dietitian working in private practice on the Central Coast, as well as Dr. Alison Lancy, who is a GP and RACGP Deputy Head of Training for the Hunter, Manning, and Central Coast, and the beautiful Dr. Georgia Page as well. Now, this is our first session using GoToWebinar. So once I am done my portion, I'm going to switch all of the attendees. Welcome to Gordon, Almut, Kelly, and Renee so far, and I know we have a bunch more joining. So throughout the session, I'm going to be switching you all over to panelists, where you will have access to the chat box, so we can all see it, facilitate it. You'll be able to turn on your camera, use your microphone, as usual, but just do it at your leisure if you want to be seen this time of the morning or not. So before we get into it, I also want to acknowledge the traditional custodians of the land that we live and work on. For a lot of us on the Central Coast, that's Darkinjin land, and I'd also like to pay respect to elders past, present, and emerging. At the end of the session as well, you will receive the evaluation. It'll come directly to you. So please fill that in for us because you know we love it so much. But we'll hand over to Gina, who's going to start, and then Alison will wrap up today. Georgia will be manning the question box, but anything you need throughout, just don't hesitate to ask, guys.
Thanks, Sydney. I'm assuming you can hear me. So all good? Can you hear me, Georgia? Yep. Okay. So today we're going to be unpicking the picky eater. I think it's something that we tend to see so much in practice, and I'm hoping after today we can have a little bit more clarity about what is normal, and then also red flags to really think of or understand when we look at the picky eater. So a little bit about me. It's not working. Hold on. There we go. I'm an accredited practicing dietitian. A lot of my work is in tertiary care, specialist children's hospital. And then I went into private practice, really focusing on prenatal, postnatal nutrition, infants and kids, and hoping to give a little bit of nutritional support in a very vulnerable space. So today we're going to look at what is correct nutrition, why does it matter, where are we at in terms of our kids in Australia, looking a little bit at the art of eating, discerning what is normal versus problematic picky eating, and when picky eating actually then becomes a problem, and then what we as health professionals can do. So we all know that improved overall nutrition with regular, structured and balanced meals improve a child's ability to learn, process information, and manage emotions. I think it's something that we often take for granted. And I guess to set the tone, I just wanted everyone to get a bit of an understanding of where our children are at in Australia and how are we faring. Only 6% of kids between 2 and 17 meet their vegetable recommendations, and about 4% will eat no vegetables at all. Iron intake is low, and a third of children have been found to eat no meat or appropriate meat substitutes. A third eat the recommended serves of whole grains, cereals, and grains, so our smart carbs. And over 50% of Aussie kids actually don't meet their daily fiber targets. We're doing a bit better with fruit, so 75% will eat the recommended serves. 1 in 4 kids now between 2 and 6 are considered overweight or obese. And 7% of children will consume a sugar-sweetened beverage daily, quite a high amount. I think this is probably one of the more concerning stats as well, is that a third of children will meet their energy requirements from discretionary foods. So those sometimes foods, junk foods, whatever you want to call it, but that's a really high percentage. So if we summarize that, you can see that our young kids in Australia are consuming foods with minimal diversity. So when I talk about diversity, and this is important, we talk about diversity in taste, diversity in texture, and then also the diversity in nutrition, and with a real focus on protein, fiber, and iron being low. And so that's our base point that we're starting at. So eating is not easy, and I think we take for granted that it's something that you're born, you know how to drink, you know how to eat, but it's really a complex skill requiring patience and practice, a little bit like learning how to walk or run. There are 8 different sensory systems at play when a child is learning how to eat. So we know that it's sight, touch, sound, smell, taste, obviously. So those are the basic 5 senses. But then there's also proprioception, which is your position or your location and the movement of your body. So sitting at a table, having to be balanced at a table, which then is your next sensory system, the vestibular system, so your balance and your orientation of your body. And then the last one is interoception, which is your ability to read your body's internal signals or cues. So whether you're hungry or satisfied. So a lot is going on for any young child learning to eat. And we know that children can either be over or under respondent and sensitive to any one or more of these systems. And that would impact their ability to become competent eaters. We also have normal key stages of development of eating and drinking, food and liquid. So I won't go into too much detail here. You will get the slides, but important to know that in your 0 to 3 months to 6 to 9 months, a child will be able to progress in their oromotor skills from just sucking movements and having quite a sensitive gag reflex to 6 to 9 months having a little bit more jaw stability, able to start having more appropriate tongue movement in order to start munching, and that gag reflex, which is often a protective mechanism, starts reducing. They also are able to hold objects and food specifically and play with it more eloquently and more effectively. And so by about 12 months, we should be able to see that the tongue movement is able to move food from side to side. There's stabilization of the jaw. Chewing has developed more significantly. Lips are able to close, and there's less spillage. And so we always talk about a child should almost eat like a giraffe. So have that kind of, if you can picture that, that's really your ideal chewing that you would like to see, with that good rotary tongue and jaw movement. And so by about 2 years, 24 months, you should have a relatively confident eater with appropriate oromotor skills. So I just put that there for a reference as to what is normal. So how do we discern normal versus your problematic picky eater? Importantly, what is that impact on a child's healthy relationship with food? I think first and foremost, as GPs, you are usually that first port of call for a parent to come to if they have concern. Parents need to know that when it comes to picky eating, they actually aren't alone. So picky eating affects anything from 25 to 33% of all children. And almost 85% of households with kids between 1 and 10 have parents that have identified their kids as being considered picky or really unpredictable eaters. The other thing is, as I said to you before, it's something, learning to eat takes practice and it takes time. And we know now that it for a child to be comfortable with a new food and actually feel familiar with the food can take many times of trying. And the literature says 15 to 20. So it's really important that parents know that they shouldn't give up when it comes to trying new things and trying new foods. And so again, building on that normal development of young children and toddlers, we know that after the age of 12 months, children will naturally become more selective. It's a normal part of growth and development. And parents should be given guidance as to discern gagging as opposed to choking. So gagging being a normal reflex, where choking is that problematic reaction to food getting stuck. Generally, normal picky eating and that normal development of selectivity will actually resolve. And so we need to try and reassure parents and help them to know that they're not alone, and to just keep positive experiences with food. After the age of 2, and again, this is usually between that 2 to 5, that's where we see this really picky eating kind of evolving. We also know that other things are happening with our kids at this stage. So their growth rates are actually slowing down. They're not growing as quickly as what they did, particularly in that first 0 to 12 months. They also are becoming more active, and there's increased intellectual and social abilities developing. So it's a time of growing independence for kids, and we find that they are expressing their individual preferences in many things. And in an adult-dominated world, food is that one thing that they can exert control over. So that could be positive or negative attention on food, and we know that that's a normal progression in their development. They've got this increased fascination with the world around them, and to be honest, they lose interest in food because sitting down and having to eat a meal within the conforms of what adults want them to do is actually just really boring. And it's a bit of an intrusion with their main business of life, which is playing. So it's important that parents are kind of given that perspective with normal development, and that at this stage where their growth rates have slowed down and they are more active, their appetites can really fluctuate while still having a very small stomach capacity. Okay, so that's normal. When does picky eating become a problem? And I guess knowing that we're starting with children that do have limited diversity in taste, texture, and nutrition, it's something that we really do need to be mindful of, that picky eater could progress to something that's a little bit more problematic. So a few definitions that I'll just go into, looking at a picky eater versus a problem feeder and ARFID. So general picky eater is what we've just spoken about here. It's where your child will have limited variety of foods, but generally they will eat at least 30 different foods, and they'll eat at least one food from most of your texture groups and your normal food groups. They could avoid new foods, but they will tolerate them on the plate, and they do tend to eat better with their peers than what they might in the environment of their parents, and they do like to be served more sort of special meals. This would usually affect around 1/4 to 1/3 of kids. Your more problem feeder, which can impact around about 6% of children, it tends to be feeding difficulties for an extended period, so more than sort of 2 years. And here we find that children are restricting their food even further to less than 20 different foods, and they will start demonstrating really strong food likes and dislikes. It could be associated with tantrums and refusal to try new foods. You will at this stage be seeing growth and nutrition problems as well, and they will definitely demonstrate skill deficits. So looking at that normal oral motor development, that would definitely be now more noticeable. And usually they like to eat very different foods from family and others, and they may even want to eat alone. So this is an area that's kind of developed quite significantly in the last 5 years, where we now have a definition where the problem feeder is now being called a pediatric feeding disorder. And importantly, it's identified impaired oral intake being not age appropriate and associated with 4 different domains. So medical, nutritional, feeding skills, and then psychosocial dysfunction. And this is helpful because I think it really allows us to identify red flags early on. I am going to just mention ARFID. ARFID is avoidant restrictive food intake disorder. It is considered more of an eating disorder, and we will usually see significant weight loss, nutritional deficiencies, and dependence on enteral feeding or oral supplements, as well as marked interference with psychosocial function. This is your more extreme manifestation of your picky eating, and it's really persistent failure to meet any appropriate nutritional requirements of your child, and it tends to be linked with other mental health issues. So our focus today is really more around that picky eater and your pediatric feeding difficulties. And so when we look at your underlying causes for picky eating, we need to remember that they are multifactorial. They tend to have issues with developmental stage. There might be a underlying medical problem, oromotor cause, sensory dysfunction or sensory sensitivities, and then a broken division of responsibility. And we find that in your most picky eaters, generally your developmental stage of normal eating, as well as that broken division of responsibility, is where you will almost always have a problem present, and then you might have the addition of an oromotor issue, medical or sensory as well. So identifying red flags and what we as health professionals can do. I've kind of broken this down into 5 key things to try and focus on in discerning and getting to the bottom of what the problem is, while still reassuring parents and helping them to try and still create a positive environment and a positive impact with food, and so it doesn't negatively impact your child's relationship with the food, as well as that caregiver child relationship, which is so important to maintain. So first and foremost, we want to explore our underlying causes. So looking at the medical causes, and I know Alison will go into a little bit more detail with this, but the medical causes that can contribute to poor appetite, and these could be short-term, but they can also be more long-term. So any illness, whether it's a cold or flu, tummy bug, diarrhea, is going to impact poor intake and overall appetite. Reflux, definitely, if a child is experiencing pain or discomfort when they are eating, we know that they will then become conditioned not to eat. And so this can further impact their eating behavior. So reflux, enlarged tonsils, adenoids, if a child is a mouth breather or snoring, again, it starts becoming really difficult to eat, where you expect to close your mouth and still be breathing optimally at the same time. Constipation is often overlooked, and if you think back of where our kids are starting with more than 50% not meeting their fiber requirements, we are sitting with a lot of children who maybe don't have appropriate bowel function, which has a huge impact on appetite as well, and that kind of discomfort that kids can't necessarily articulate very easily. Allergies and intolerances, well, again, here's really important to get to that correct diagnosis, as opposed to maybe a perceived allergy. It's important for us to know what is the food that the child is reacting to, so that we're not unnecessarily eliminating other foods and restricting foods that don't need to be restricted, because this can really predispose a child to further nutrient deficiencies, food neophobia, where they're scared to try new foods. So importantly, we need to try and get to the correct diagnosis. A child that has low zinc or iron status, again, thinking back on where our kids are starting with their normal nutritional base, iron is one of those nutrients that we really are concerned about, and our kids have got very low levels. So here we need to be sure that we're giving the right advice in terms of introduction of solids, helping mom to understand that kids need to be getting iron-rich foods from an early stage when they are ready to eat solids, because low zinc and iron can impact poor appetite as well as oral intake. Medications can have an impact on appetite and nutritional intake. Chronic disabilities ADHD, as well as autism, anything in the autism spectrum disorder, ASD, depending on the level, if there's any sensory sensitivities that often go part and parcel with these children, these are things that could impact their overall food intake. And so importantly, we need to make sure that kids are always feeling safe and in control to enjoy their eating. When we look at oral and motor or sensory causes contributing to poor appetite, tongue tie is one of those things that we often don't think about, but looking at a child's history early on, are they able to latch easily? Was breastfeeding ever difficult? Or any kind of feeding from a bottle if they weren't able to breastfeed? Was there ever poor control of chewing or tongue movements and progression to that normal progression that we would want to see to different solids? Is there frequent gagging that seems to be more problematic? We need to get a bit of an understanding of the history of any poor feeding practices and also any negative past food experiences. Remember, when a child has had something negative around food, that can absolutely inhibit their ability to have another normal interaction with that food potentially in the immediate future after that experience. So if a child maybe had a choking episode or was force-fed a certain food, that could all contribute to poor appetite. And then, as I alluded to, sensory sensitivities, with or without a medical cause, whether it's sound, touch, texture, visual, smell, can translate into the food experience. And so I've included a really easy feeding question screening tool or questionnaire that can really help that early identification of your pediatric feeding disorder. And so if you look at these questions, it's 6 questions, and those that I made pink, those are your red flags if the child or mum answers those questions in pink. And if there are 2 or more of those answers that are highlighted in pink, then you need to really look to seek additional referral. And so when there is that problem, who do we consider involving? And so what I've done is I've summarized kind of who those further medical referral would be, where you would seek more medical referrals, whether it be a gastroenterologist or an allergist, pulmonologist, and then your allied health referral team, whether it be a nutrition related problem, you'd then look for an accredited practicing dietitian and nutritionist, feeding skill related problem, occupational therapist and speech pathologist, and any psychosocial issues, you definitely look for guidance from a psychologist and social worker. And so early detection and referral and treatment of your pediatric feeding disorder across all 4 domains is really critical for that long-term health and well-being of any child that's affected. Looking at the signs and symptoms that we would then think requires allied health involvement, I've put this in just to be kind of break it down a little bit more for you, but I think it's important to remember that you often need more than one allied health professional to get involved. And so just as an example, for nutrition, if a child is unable to eat or drink enough for optimal growth and stay hydrated, you'll see that that also has an overlay. We have that also for your feeding skill component. So really that child, if there is sensory involvement, would benefit from both a dietitian as well as an OT or a speech therapist focused on feeding. Remember, as GPs, you are able to help your patients and help parents with chronic disease management plans and team care arrangements. And so when we're looking in the pediatric space, and I know Alison will go into more detail here, but there's no specific list, but importantly, we need to know that a chronic medical condition presents for more than 6 months or longer. And when you have complex care needs, that team care arrangement can be really beneficial to get more multidisciplinary involvement of your GP as well as then at least 2 other collaborating healthcare providers. And parents can then get benefit of at least 5 support services within a calendar year. So as a dietitian, I guess for me, seeing chronic conditions within the pediatric context and those requiring ongoing long-term nutritional support, I've really just summarized the ones that tend to present with the child and the child will have it for 6 months or longer, or they may only come to you with a problem after a number of months. And we've got food allergies, celiac disease, inflammatory bowel disease, any nutrition deficiencies, specifically iron deficiency anemia is the one we would be really concerned about as a starting point. Failure to thrive, or a child that was born extremely premature and may have developmental delay and feeding developmental delay. Any complex feeding or swallowing difficulties that are impacting their overall intake. The pediatric feeding disorder, red flags, constipation, and ASD. So any child on the spectrum where it's impacting their intake. And then children who are from vegetarian or vegan families requiring additional nutritional support. We then need to help discourage pressure tactics. This can be easier said than done. And I think it's important to remember what form pressure can take. Pressure, we know from the literature, can reduce a child's innate ability to self-regulate appetite, knowing when they're hungry, realizing when they're full. And so when we talk about pressure tactics and impacting food intake, guiding parents as to understanding what that could look like, it could be praise and rewards, comparison with a sibling that might be eating better, or friends, guilt, after you've cooked a meal and taken a lot of efforts and it's not being eaten, bribes in order to try and eat the more nutritious foods, force feeding, threatening, and then also nutritional education, particularly when a child is not mature enough to actually take that on board where it has an impact. So understanding what appropriate conversation is around food is really important. And when it comes to the research, I think importantly for parents to understand that higher levels of parental pressure are actually associated with children eating less, weighing less, and having higher levels of pickiness. So it does really backfire, unfortunately. Also, when we label foods as a forbidden food and we restrict their intake, we know that children will actually want to eat more of them when they do get the chance. And it actually is now associated with more overweight in kids that have been restricted from eating certain foods. The most important determinant of a child's liking of a particular food is actually the extent to which it is familiar. And so this is where positive role modeling is really important. It seems to be the strongest predictor of lower food pickiness, specifically children's fruit and vegetable intake, and the likelihood of them trying a new food. We know also that there's a positive relationship between the frequency of family meals. And again, it's this exposure, teaching children how to eat and when to eat, increased self-esteem, school success, reduced disordered eating, as well as eating disorders in adolescence. So really important for parents to understand the role they play in getting to that positive relationship with food. I just put this as a highlight. So we know that children will consume more food, specifically vegetables, when they're not pressured to eat them. It's a bit like when you try and get a child to sleep. Getting them to sleep and telling them they must sleep probably won't happen very easily. Okay. As healthcare professionals, we need to understand normal growth, and we need to inform parents of normal growth. And so when we understand that normal development and that a child's growth slows down after the age of 2, that's also important to let parents understand that. When we are plotting growth, we need to use the correct growth chart. So generally now in Australia, the WHO growth charts are used until about the age of 2, and then the CDC growth charts from 2 years onwards. And if you have a premature child, it's important that you adjust their age until they are 2 years. For children looking at their growth trajectory over time is important. If there is a change, we need to understand those pattern changes and try and find possible explanations. Always consider genetics. That 50th percentile is not our goal, but rather understanding within the context of the child's genetics and where they have been growing with their growth trajectory, what is that growth curve that that child is needing to attain? And this is often really helpful for reassuring parents. So I just put this in as a bit of an example. If we were to be following a growth trajectory, you can see that in this child, round about that 2-year mark, growth started plateauing or flattening off, and then actually crossed a centile. And so really at this time, this is an important screen for us to understand what happened. Was it a short-term episode of illness that contributed to that weight loss, or is it something that's a little bit more sinister and a red flag that we need to now be getting involved and helping to understand the problem? As healthcare professionals, when it comes to eating, we need to work on long-term, not short-term solutions. And so understanding that our overall goal should be working with parents to build competent eaters. This is really important. We need to create positive relationships with food and make sure that children are allowed that opportunity to explore and always see food in a positive light. This takes time, patience, and always regular exposure. And so one of the things I had mentioned when we're looking at the problems we tend to see with picky eaters, one of the things that I mentioned was a broken division of responsibility. Now, the division of responsibility is something that's often quite helpful to remind parents of. And this was created by Ellen Satter, who is an accredited practitioner or a registered dietitian in the US, and she has the Ellen Satter Institute, where they really have unpicked and their specialty is really helping parents and healthcare professionals in the picky eating space. So the division of responsibility is understanding what a parent's job is when it comes to feeding a child, and then what the child's role is. And so the parent's job is the what, so what the child should eat. That's really where they play a vital role in providing that food. They decide where to eat, so whether it's at a table, or is it a carpet picnic, or is it outside. And they also decide when, so having those defined, structured meals. The child's role is very different. It's the child that decides how much they want to eat and whether or if they want to eat. And so knowing that the child's appetite and intake changes from day to day is also very important to remember for a parent. These are old studies, but I did put them in because they're probably the only ones that talk more around understanding whether parents actually follow the division of responsibility. 85% of parents in an observational study said that they always tried to get their child to eat more. And so again, it's that slight coercion of getting a child to not listen to their natural cues of being full and satisfied versus hungry, and pressuring to eat. And over 90% said that they did bribe, reward, did short order cooking. So we're cooking different options for children based on what they said they wanted on a day, to pacify their kids with food, as opposed to finding other ways to regulate. And they also didn't believe their children when they said that they were full. So this is really important because it can have a huge impact on, again, developing that competent eater who's able to make those decisions for themselves as they grow. So something I always tell my parents, you provide, they decide. I think it's a really easy way to remember, but for parents it can be quite helpful in understanding, as long as they're providing the correct options and at the correct times, the child can decide if and whether they're hungry and how much they'd like to eat. And then lastly is to set realistic expectations. So importantly, as healthcare professionals, we need to understand what is the feeding dynamic between your child and your caregiver. Parents at all times need to be a positive participant in that feeding relationship. Otherwise, it's very tricky to get a successful relationship with food for the child. We know that parents, when it comes to picky eaters and having to deal with problem feeders, parents can really experience a lot of reduced capacity for intervention. It can be extremely overwhelming. Sometimes they can be embarrassed with the idea that they're not able to fulfill their child's nutritional requirements, and a huge burden of concern, particularly if the child is presenting with some kind of growth faltering. So at the outset, understanding the parent's expectation, their own readiness for behavioral change, because really these are changes that have to take place within the family structure as well. Role modeling is extremely important. Parents need to role model eating the foods that they want their children to eat. They need to eat those foods in front of the kids and with them. We need to support and reassure. Look at a child's intake week by week rather than day by day, because this is a really far more realistic exposure of what the child might be eating. And then encourage responsive feeding practices. And so if there are 3 take-homes that you can give to your parents as a starting point for family strategies for picky eating, it's these 3. So to create a positive environment, keep feeding calm and relaxed, allow children to be independent feeders when they're able to, so depending on their skill set and where they're at with their eating journey. Children need to be sitting comfortably at the table. So as I said to you before, when you think of those sensory systems that are at play, learning to eat, if a child is sitting at a table, their feet are dangling, they're unable to balance easily, they are expending a lot of energy just to sit in front of that food and not move. So putting simple things like supporting their back, putting a stool under their feet can really help to just let that child focus on the food in front of them. Limiting distractions, encourage family meal times where possible, set a time limit for meals, so not sitting for 2 hours to try and get a child to eat 3 mouthfuls of whatever food is remaining on the plate, and always to avoid pressure and forcing. The second one is to start regulating appetite. Really important that we avoid that constant grazing on foods and liquids through the day. So understanding how much liquid is a child consuming, because when you've got a small stomach capacity, liquid can displace the food that needs to be eaten. Rather start with serving small portions, and the child can always ask for more. So making sure that parents are, as a basic rule of thumb, 5 having those 3 main meals a day, and then 2 to 3 snacks to promote that hunger at mealtime is really important. And it's okay for food to be left on the plate. And then exposure. So introduce new foods. Regular exposure, as you saw in the research, is really one of those things that's the most likely predictor of a child being comfortable with eating that food. So a child must recognize a food in order for them to eat it. We want to make sure that new foods are usually served alongside familiar foods as well. So for some children that could be overwhelming if not. And again, having more family style meals, eating together where children are seeing new foods in context of a positive environment is an important thing for them to see, where parents are eating new foods and they can also experiment and discover and eat those foods as well. We need to allow new foods and eating of foods to sometimes be messy and playful. So seeing food not just as something that must be eaten, but that's where snack times can be really helpful, where it's just food presented in a different way. Keeping food fun and mixing it up a little bit. So for a child, a version of a familiar food is actually a new food. So potato chips versus mashed potato, in a child's mind, that's actually a new food. So you don't have to be too kind of creative in a sense, but really just changing the versions of foods can be extremely beneficial in exposing different types of foods. Involve the kids in the kitchen with meal prep or laying the table, clearing the table if they're old enough. And for all parents, really important for them to know that they must not give up when it comes to offering different foods, even if the child has refused it in the past. And so a reminder for me to give to parents is that kids eat in color. Keep it fun, keep it engaging. Let's not kind of get too lost in trying to educate them when they're not able, when they don't have the maturity really to take that on board. Just make food fun and engaging. And I think when we do that and we remember our roles as parents and their roles as kids when it comes to the eating, it really can help in alleviating some of those pressures around food. I've included some references for you to go back to if you'd like to. And yeah, here's my details. If anyone has any questions or needs support at any point, please don't hesitate. I am on the Central Coast. And I think we probably will go over to Alison now, or questions, I'm not sure.
I have a question, Gina. What's your thoughts on the whole baby-led weaning kind of, I don't know, model, I guess, in terms of the acceptance of like kids accepting more foods or later on?
Yeah. So if we look at what the research says in terms of, for those who don't know, so baby-led weaning is where you are basically letting the child decide what to eat, but they are being given finger foods almost from the outset, so from 6 months. And as opposed to your traditional feeding, which is, you know, starting with more spoon, purees, and then progressing to more lumpy foods and finger foods as the child's skill levels progress. Looking at the literature, there's very little to say that one is specifically better than the other. There are concerns for some, so for example, baby-led weaning, some parents will restrict their children's overall diversity of food because they're worried that the child might choke. And that's, again, just more parents lacking that confidence and being uncertain. And then on the other side, when you have more traditional, we have the problem of children maybe not deciding when they're full or not, parents potentially giving too much food at one point, but also maybe not progressing to more textured foods. I think when we look at advising parents, it's important that a parent chooses that route of feeding that they are most comfortable with. However, we need to inform them about the nutritional composition of foods. And so we know that our infants are starting with low iron levels as a base point. And so iron-rich foods tend to be those foods that are a bit more tricky to eat, right? So it's your meat, your chicken, egg, and what people tend to forget is that legumes are actually really good sources of iron as well that we can incorporate, and they're very easy to squish in your hands for a child to be able to process in their mouth while they still are developing that oral motor skill. So I think it's more around informing a parent of options, and parents might feel more empowered if they are able to do almost a combination of both, where they still able to give those iron-rich foods, because we know that with baby-led weaning, that is one of the risks, because giving a stick of chicken for a child to eat or chunks of chicken is not necessarily going to translate in that child being able to process it in their mouth and ultimately swallow it. Yeah, they might play with it, but it might not ultimately be swallowed. And so giving parents that ability to almost combine the two can be really helpful. And so I would probably always say to a parent, if they are choosing baby-led weaning, they need to then focus on those iron-rich foods as well.
Right. Thanks for that, Gina. I was really enjoying your talk. It was really, really informative, really interesting. It was interesting you talking about because some people might know I used to be a dietitian, a pediatric dietitian, many, many years ago at Westmead Children's, and the kind of eating disordered, we saw lots of kids before it kind of had a diagnosis, like younger kids where they just had made the decision they weren't going to eat anymore, and that was it. So sort of kids under 10. And it was really tricky, like, because it was treated as an eating disorder, but it didn't respond in the same way that eating disorders responded for teenagers because of the kind of fixation. So it's really interesting to see how that's progressed. The literature and the research has progressed in that space in the last sort of 15 years.
Yeah, I think, you know, I guess sometimes before the diagnosis of that pediatric feeding disorder, definitely an eating disorder tended to be that diagnosis. And it's a very enormous diagnosis to give a child, right? And it can lead to really extreme ways of thinking too for that child and the parents.
Yeah. Yeah. Now there's a question in the box. That's right. All right. Well, I might start because I've only got a couple of slides because Gina's presentation is so awesome. I really didn't feel like I had a lot to add to it.
And just to say, Alison, I think I've got your title. I've been called Dr. Gina Steer. I'm not. you need the title in front of your name.
Yes, I said if you don't mind clicking to the next slide. So I guess what I really wanted to focus on is just looking at sort of red flags. So Gina's done a great job of talking about what's normal and some of the conditions that can present, you know, with picky eaters and things like that. But what are the sorts of things that if you're hearing this or a parent tell you about fussy eating or having problems with food or eating, or that you're worried about kind of growth, these are some of the things that it's really important for you guys to be asking about. And one is about developmental age and and any kind of developmental delay across any domain. So I know on Health Pathways there's a great localized one about developmental concerns in children, so you guys can have a look at that. And it's got a couple of screening tools as well. So if you're not quite sure about what the ages and what kids should be doing at certain ages and things like that, I would really strongly recommend that you guys have a look at that. Any kind of developmental delay across any domain. And I guess the other thing is if the parent starts talking about any kind of regression at any age, there's a couple of like neuro disorders, and also you know, you've got ASD that can get this kind of regression. Or if you start exploring the developmental ability of the child, you notice that there's a lack of eye contact, or they're kind of not interested or engaged with the parent or with their kind of surroundings. Those things are certainly a significant concern. And another concern too is, you know, if there's any signs, history, or concerns about child abuse, neglect, or domestic violence. And I mentioned this later in the slide, or significant mental health concerns in a parent or a child living in out-of-home care. So all of those things can significantly impact on the developmental ability of the child, the stress in the household. And Gina did such a great job of talking about how, you know, the environment at meal times makes such a big difference to kids. So if the house is very stressful, if there is a significant lack of control that the child has in the house, then you channel it in something. And food might be the only thing that they have any kind of control over. And so that's really, really important to kind of tease out if there's any kind of concerns there, and to ask, particularly if you've got the mother or the caregiver, you know, is everything okay at home? How's your relationship with your partner? You know, those kinds of questions to try and tease it out. And we certainly, with a lot of you guys, with the registrars, I talk a lot about domestic violence next term. But at the moment, the primary health networks are coming around to practices and doing a lot more education in that space as well. So talk to your supervisor about that if you haven't already seen what's happening in that space. Any kind of acute onset of changes, particularly if there's significant behavioural change or self-harming type things. So there are, if there's a sudden change, you've got to worry about, significant medical condition, infection. I've certainly seen kids present with idiopathic intracranial hypertension that suddenly results in a significant change in behaviour. And so, things like that can certainly affect eating habits as well. So if this is an abrupt change, then you need to be looking at what is the potential cause for that. Jenny's already talked about weight, crossing centiles, significantly poor growth, but as she was saying, like, it's all relative. So for me, I was always well under the 3rd centile growing up. I'm not a tall person, but my daughter is 50th centile. I swear she's going to be taller than me when she goes to primary school. So, it's all relative, and genetics of the parents is very important to consider that too. And I think too, we often have this, we have a very skewed idea about what a normal looking child looks like. And so sometimes I've seen parents say, oh, they're too skinny, or everyone tells them they're too skinny, but actually, like, their growth is completely fine. We just have this kind of skewed idea that kids should be kind of plump and, have lots of baby fat and that kind of thing. So that, it's important to make sure, and I do this with every single child that I see, it doesn't matter what they've come in for, I always do a height and weight. And then plot it on the growth chart so that you can see that, and you can oh, look at their growth, aren't they going really well? You're doing a great job, mum or dad. So, make that part of your routine with every child that you see, that you do their height and weight to check their growth. As I mentioned before, care and mental health issues, that can be like, and again, that just affects the environment in the home. It affects the environment around mealtime. So it's really important to be assessing that. Yep. So yes, any kind of change in bowel habits or poo. So as Jen was saying, constipation is like so common in kids, and it has such a big impact on appetite, tummy pain. It can lead to significant iron deficiency. Lots of different things like that. So, but there are also disorders that you can get partial obstructions and various things like that that can have a significant impact on appetite. Or if there's a family history of any kind of GI disorders, so suddenly they've got lots of diarrhea, or the poo changes color and starts looking reddish, you worry about inflammatory bowel conditions, about celiac disease, partial obstructions, various things like that. So any kind of really significant change, you might think about a more severe medical cause as opposed to just kind of, this is just straight constipation. And feeding into that is that, if they're getting recurrent episodes of vomiting or diarrhea, you've got to be thinking about, is there kind of some kind of gastrointestinal disorder that that I'm not picking up here? And lethargy is the big one. So any kind of lethargy, you'd be worried that there is some kind of medical issue going on. I've certainly seen, so cystic fibrosis is one of the most common genetic disorders in Australia, and I've certainly seen lots of cases of that not being picked up until kids are older, sort of toddler or early childhood. There are rarer genetic versions of that aren't picked up on the newborn screening, and so often they present with, tiredness, failure to thrive, poor growth, all those kinds of things, fussy eating. So any kind of lethargy, you do worry about there being an underlying medical cause. So it could be GI, cardiac, neurological, and so if mum is saying, oh, they're just really tired all the time and they're struggling to eat, then you really need to start doing an assessment to see if there's some underlying significant medical cause for that. So self-harming behaviours or aggression, again, that comes with that behaviour change. Is there some kind of intracranial issue that's causing a behaviour change or significant self-harm behaviours? That also can tie in with the abuse, domestic violence, neglect. There's lots of things that can all tie together. But if there's significant self-harming behaviours, you really need to be doing a very in-depth assessment to find out what might be going on. And then, as we mentioned, so any kind of family history, so any GI disorders, diabetes, or autoimmune disorders. Basically, it's like the cluster that all goes together, and certainly any of those history can increase the likelihood of a child having celiac disease as well, and that can be diagnosed at any age. But you know, or significant family history of allergies or food intolerances, you know, you might worry about that as well in a child that's presenting with change in eating habits or significant, I guess, picky eating or disordered eating, I guess. So in terms of medical causes, Gina's already covered a lot of this. So like these are sort of like common. So constipation, common. Celiac disease, not common, but you always think about it. Yeah, things like eosinophilic esophagitis. So these can be some of the causes for things like reflux. So, and that comes out with your history. So is there, you know, vomiting that's associated with it? Is there pain? Is there food refusal that seems to be pain related, or an adverse, you know, or linked to particular foods as well? So sometimes you might see that, you know, that if kids are having a reaction to a particular type of food, like the celiac disease or food intolerance, then they sort of start self-selecting away from that food because they know that it's going to give them tummy pain, or it's going to give them diarrhea, it's going to make them feel sick. So trying to explore that, and a dietitian is best placed to explore a lot of these things. They've got way more time than you do to be exploring these. You know, is there a particular food that is contributing to this? You know, things like food protein induced enteropathy, GORD. And again, a lot of these have got really great health pathways, localized health pathways that you can have a look at that will give you, you know, the red flags for the particular conditions, you know, what to do about it. And so I would strongly recommend that you have a look at those to get a stronger handle for yourself. So cerebral palsy is quite common, and so there are cases where it may not be picked up and may not be particularly obvious at birth, but if there's any kind of concern against, you know, developmental delay, low muscle tone, you know, slow to sit, slow to talk, you know, anything like that, then it's really, really important that that's followed up early and there's early intervention with those things. And, you know, particularly going back to, you know, kids in out-of-home care, or if there's a history of neglect, you know, things like fetal alcohol syndrome can be, you know, it's very under-recognised in kids, underdiagnosed. There's a lot more work occurring in that space and help with diagnosing it, but kids often don't get diagnosed quite late. So that's something, I guess, to consider if there's any kind of history of significant mental health in the carer. If there is, just lost my screen, you know, if they're living in out-of-home care, or there's any kind of history of neglect or abuse. You know, hypothyroidism, absent seizures. So again, it's all about finding out what's the history, like, you know, do they not engaging all the time, and the episodes of this staring into space. You know, these things are not common, so I'm not saying that any of this stuff is common, but, you know, these are some of the rare, I guess, medical things that you need to kind of be keeping in the back of your mind, thinking about how they present in kids. Hypothyroidism, inflammatory bowel disease, I've definitely seen that in, not in like toddlers, but I've definitely seen it in children. And so it's not, you know, it's not unheard of. And then any kind of developmental delay. So there are particular conditions that, you know, take a bit of time to pick up. So like Gina was mentioning, like geneticist might be this where you might need to go to, but you're going to need a team to help you to do all of this. So Sydney, I'll go to the next slide. So don't forget the NDIS. So kids under the age of 7, you can refer for early intervention under NDIS. And you don't need a diagnosis at that point in time. So if there is any kind of developmental delay or significant concerns around behaviour and feeding and that kind of thing, always have a think about whether you might be able to do a referral to NDIS. So a GP management plan is awesome, but you only get 5 kind of visits, whereas and I would definitely use that while you're waiting to get someone on, perhaps onto the NDIS. So just as a reminder, again, so this is something for registrars I will be talking to you guys about next term, but if you've got anyone in this age group at the moment, there's a separate form for kids under the age of 7 for early intervention. So I really strongly recommend that you have a look at the NDIS website. They have a page dedicated to GPs. So I would recommend that you have a look at that. So that might be a good option, because then you can get a lot of these assessments, OT, speech, you know, physio, dietetics. You can get lots of kind of early intervention and assessments done. So that's kind of, I know we're up for time, so that was all I kind of wanted to check. So the main thing, if I can stress, is just don't ignore or dismiss parental concerns. So, you know, you might be sort of listening to the story and going, oh, this is probably the parent making a bit more of a big deal about this than it perhaps is. Don't do that. So the main thing is that it may well be, it's not as concerning an issue that the parent thinks, but please don't ignore or dismiss their concerns. Do a full history, do a full examination before you make that assessment, because you might pick up something, and parents are a really good judge of when they think something's really wrong or not. Okay. Thank you.
Amazing, Alison and Gina. Oh, that was great. And I enjoyed both talks thoroughly. And Alison, your little addition at the end complemented what Gina spoke about as well. So definitely some tips. And I think I've been feeding my children wrong all this time.
Oh, can I? Oh, sorry, I was just going to say, Jenna, one of the best things I found with my 5-year-old under that is Bluey had an omelette episode, and Bingo made an omelette, and we watched that episode, and so I was like, I want Amelia to make an omelette, and I was like, okay. And so like get that help, do what things we talk about, Gina, like getting them cooking and stuff like that. If she makes the omelette, she will eat all of the omelette. And same with going shopping. So I take her shopping and she helps, and I go, what do you want to get? What fruit do you want to get? What do you want to get for veggies? What should we have? And she is more likely to eat when she comes and helps with the shopping and when she helps with the cooking and stuff like that. Yeah.
And I think that is so true. Like making food fun, getting them involved in all those different aspects, not just the eating, right? So there's so much more in terms of kind of connecting with food. Yeah.
Oh, sorry, Georgie, you were going to ask a question someone else.
Yeah, my question was, and more again, like the mum that comes in, the fussy eater, oh, can we check their iron levels? You know, or that we need blood tests. So there's that request for blood tests. And as you mentioned before, is it going to change management? Every blood test I do on a child, they've got some form of iron deficiency. So what's your approach there?
I don't like doing bloods on kids if I can help it, because it's really traumatizing. So, I mean, any test, like, it has to really, like, is this really going to change management? Do you really think there's a significant medical condition that's causing the iron deficiency? Now, like Gina said, like, iron deficiency can affect appetite, but can you address all of the other stuff that Gina was talking about and improve their eating and improve their iron without you having to resort to doing tests? So that's kind of where I would sit. But certainly there are going to be situations where you're like, oh, this feels like significant crossing of centiles. You think there's significant red flags. Like, that's where it comes down to, like, are there significant red flags here that I'm really concerned that there's something underlying here that's not just they're not eating enough and they've got iron deficiency, that's like there's a cause for, like, there's another organic cause for it, then I would definitely, definitely consider it, and always get them to hold serum as well, because you might want to add tests later and you don't want to have to do more blood.
Right. Any burning questions from the audience? You can either unmute, put your camera on, or type in the box. But yes, I think Bluey's the perfect role model for omelettes.
Just got a comment, if there's no questions. The comment is about celiac disease sometimes having associated non-gluten food problems like lactose intolerance. So I had this boy in year 1 who had a diagnosis of celiac, and I was asked to see him because of school refusal. And the story was, that every morning after breakfast he'd be crying and wailing and wouldn't go to school, And because I've got some gluten enteropathy myself, I said, oh yeah, and what do you have for breakfast? Well, cereal and milk, Okay, and so I just got the mum to buy some lactose-free milk from Coles, and next time I saw her, she said he rang up his granny and said, "I haven't got a sore tummy today, and I'm going to school." And he
And
didn't
is
know why.
Amazing.
He wasn't told there was any difference in milk. It was
and
great.
is that the behavior stuff, it's about that kind of intuitive and listening to your child and trying to work out, like,
Mm,
they're not just deliberately trying to cause a fuss. It's like there's often an issue that's not being addressed, particularly with school refusal. Yes, and then building that independence as well, I think, is really important early on. I had Sophia, she had a significant heart surgery at 5 months, right around where you'd be looking to introduce solids. And so I've got video of her like in the spoon, like feeding herself, and then she had a heart surgery. And after that, she was like, "Oh no, nothing is going in my mouth that I'm not like holding on to." And so we had a lot of issues with her. She was like, "I am going to control anything that goes near my mouth." And so it took a lot of like dietetics, and we went to the feeding clinic and
mm,
things like that as well to assess, if there was a real issue. And she had a lot of gagging and a lot of like, so those kind of early big events make a big difference too. And chronic disease, like I used to work with a cystic fibrosis clinic, and because it's all about they need a lot of calories, there's all this stress around meal times, and they have to be eating
mm,
enough, and it just feeds exactly
mm.
into what you were saying, Gina, about that kind of
Yeah.
meal times being a battleground, and like, well, I'm going to control this because it's clearly something that really annoys you. I don't eat.
Exactly. It's the only thing they can control in that space anyway. So yeah.
Yeah, that's really interesting.
Very good. Any final questions? That was fabulous, and I'm sure many people will watch the recording afterwards as well. So I'll hand over to Sydney to do the wrap up and the evaluation, and I don't know if we're doing lucky door prizes as well.
Thank you to everyone that attended today. I thought it was a beautiful session, and yeah, I definitely took some stuff away as well. I kept thinking, although I hate YouTube with a passion, my kids love watching anything to do with food. Because they're so colorful, like you said, and there's all the colors that these people do in a colorful kitchen or colorful food. I'm like, you know what? It's not the worst thing in the world if it gets them excited in some regard. YouTube, I guess, can be positive. But yeah, thank you so much to everyone. And again, apologies. It was not Dr. Gina. I know we've spoken about that before. Dr. Lancy over there. I couldn't edit it after I did it. I was like, oh no, I'm sure people will figure it out. But thank you to everyone. Now, when I close off the webinar, I'll get the recording up in a few days' time and put it to our little private place. You'll have all of the slides available there as well with the references if you want to look into anything. And the evaluation will come to you directly after I close out. So we will see you all in another couple of weeks. Georgia, what is next on our agenda, I believe? Do you know off the top of your head?
So it
Put you on the
is,
spot there. Sorry, I don't have it open.
it's Dr. Katie Fisher and on telehealth in general practice. So based on some research with registrars, and it'll be really interesting. So looking forward to that one. Very, very relevant to what we've been doing the last few years. So.
Yeah, definitely. Perfect. Well, thank you everyone for attending, and we'll see you soon.
Thank you.
Thank
Bye.
you.